All right, well, here we are with Chapter 24, Endocrine Emergencies and Nutritional Disorders. And, when you think about all the stuff that we learn in paramedicine, endocrine stuff really takes a back seat, with one exception, and that is diabetes, because diabetes is an endocrine disorder. And we don't spend a lot of time talking about the endocrine system and the endocrine glands. And hopefully we'll be able to answer your questions that you might have concerning endocrine emergencies and give you a little better idea of what sort of emergencies we can have when the endocrine system isn't functioning properly. Now, the endocrine system has 8 glands, and these glands submit hormones and send chemical messages that are important in helping us maintain homeostasis. They include the hypothalamus, the pituitary gland, which is often referred to as the master gland, as it signals other glands to release hormones. And then we have the thyroid gland and the parathyroid located in the neck, the thymus behind the sternum, the pancreas, of course, located in the abdomen, the adrenals, which are located on top of the kidneys, and the gonads, which refer to ovaries in women and testes in men. So how do these glands communicate? I'd said that it's all through the release of hormones, and hormones can be different varieties. There can be direct hormone release, and that's cells with the same function interact with each other. So hormones within the pancreas causing pancreatic cells to function together. And then you have paracrine hormone release, and this is where paracrine factors like cytokines are released into the extracellular fluid, and then while floating around in the extracellular fluid, these hormones react with other cells within the same tissue, but not with other tissues. Remember that a cell is the basic unit of life, and a collection of cells is called tissue, but particularly a group of specialized cells is called tissue. As an example, a group of liver cells would be considered the liver. And so these paracrine hormones, these cytokines released in the extracellular fluid, react with cells of the same tissue, but not with other tissues. And then probably the most common is a synaptic release of neurotransmitters. And here we're talking about the sympathetic nervous system and the release of adrenaline or epinephrine, norepinephrine and dopamine, as well as the parasympathetic nervous system with the release of acetylcholine. But then you also have neurotransmitters like aldosterone and cortisol and some of those others that we'll talk about here. So here's a visual of where those particular endocrine glands are located. You've got the pituitary gland, which is located at the base of the cerebrum, and then the pineal gland, which also is known as the hypothalamus, which is located in the brainstem. Then we have the thyroid glands located on either side of the trachea in the neck, and the parathyroid glands located on the posterior surface of the thyroid glands. They're not showing the thymus gland, which is located under the sternum. And then the pancreas, located in the abdomen, the adrenals located on top of each kidney, and then the gonads, including the ovaries in women, and the fallopian tubes, and the testes or testicles in men. Now, the hypothalamus is the command center of all the endocrine system. It sits in the cerebrum of the brain, actually cerebral cortex in the center of the brain. It's made up of nerve cells, and the hypothalamus receives input from the autonomic nervous system. And the autonomic nervous system is, of course, divided into the sympathetic and the parasympathetic nervous systems. The hypothalamus produces and releases hormones that trigger target tissue in the anterior and posterior lobes of the pituitary gland. So it's actually the hypothalamus that triggers the master gland, the pituitary gland, to send signals to other glands to release their hormones. So the hypothalamus regulates hormone release in the body. It regulates hormones the regulatory hormones that are released by the hypothalamus direct the pituitary gland to either increase or decrease hormone production and help coordinate different body systems and help maintain homeostasis. So some of the hormones released include the growth hormone, which of course determines how tall you grow. Lack of that would create dwarfism. The corticotropin hormone is corticosteroids, which are important, as we'll talk about here in a bit. And then the thyrotropin have to do with thyroid stimulation. The gonadotropin have to do with stimulation of the gonads. Prolactin has to do with the production of milk in lactating women. And these hormones are either released in excess or inhibited. One pause here. All right. Talk about the pituitary gland now. The pituitary gland is the thermostat for hormone-producing glands. In the anterior lobe is where endocrine cells produce hormones of the pituitary gland. And again, we already mentioned that the pituitary gland is regulated by hormones produced by the hypothalamus that are deposited into the bloodstream. And we already mentioned those hormones that are produced by the pituitary gland, to include the growth hormone, the adrenal corticosteroid hormones, the thyroid hormones, the follicle-stimulating hormones, luteinizing hormones, and prolactin hormones. The posterior lobe of the pituitary gland contains distal ends of some hypothalamic neurons that produce hormones that are not released into the bloodstream, but they're stored in secretory vessels. And they include things like the antidiuretic hormone, which lack of may cause diabetes insipidus that we'll talk about, and oxytocin, which is stored and released if there is a need to stimulate fetal delivery or to stimulate contractions. We carry that one, of course, in our drug kits, or some carry them in their drug kits, known as a Pitocin. All right, the thyroid gland sits in the neck, and it affects almost every organ in the body because it's important for normal metabolism. Thyroid follicles contain suspended proteins that cause the gland to release TSH, or TSH causes the gland to release T4 and T3, which are your thyroid hormones. And when released, these increase cellular metabolism. And it also has something to do with the production of or storing of calcium. The parathyroid glands, there are 4 embedded glands that are within the thyroid itself. They increase fluid calcium levels, and they also cause calcium release into the blood by the bones and the kidneys, and they also are important in the reabsorption of calcium and bone strength. The thymus is located in the mediastinum behind the sternum. It releases several hormones, to include thymosin, which promotes the maturation of the T lymphocytes, which are the white blood cells that are responsible for immunity. The pancreas sits in the abdomen just below the stomach and reaches back into the retroperitoneal space. The pancreatic acini connect to ducts that deposit an alkaline enzyme-rich fluid directly into the digestive tract. And the fluid is pancreatic fluid, which is used in the digestion of amino acids. The islet of Langerhans produces several cells. From the islets, alpha cells produce what's known as glucagon, and glucagon is essential for increasing blood glucose. And the beta cells in the islets of Langerhans produce insulin, which is important for decreasing blood glucose. And the delta cells produce somatostatin, which has to do, of course, with the regulation of cholesterol. And the F cells produce pancreatic polypeptides, which are important in the digestion of amino acids. So insulin decreases blood glucose level, and it prompts the liver to convert what sugar is in the blood into glycogen through a process known as glyconeogenesis, or excuse me, a process known as glycogenolysis. And later, when needed, it's glucagon that triggers the liver to release that glycogen back into the bloodstream through a process known as glyconeogenesis. And these are just slides of the alpha cells and the beta cells found inside the pancreas. The adrenal glands sit on top of the kidneys, and it's the adrenal cortex that surrounds the inner adrenal medulla. And the adrenal medulla is where the endocrine cells are located. And the adrenal medulla then releases adrenocortical or corticosteroids and steroids, which are essential to life. They help regulate blood glucose levels. They include cortisol, aldosterone. They promote the peripheral use of lipids. They stimulate the kidneys to reabsorb sodium, and they also aid in anti-inflammatory effects. The adrenal medulla also releases adrenaline, which we know, of course, is the synthetic man-made epinephrine, and the other adrenal-like hormones to include norepinephrine, which is primarily pure alpha and causes vasoconstriction, which helps raise the pressure in the system, and then dopamine, which has different effects at different dosages in the body. At lower doses, it dilates the renal and mesenteric arteries. At higher doses, it dilates the at the mid-range, it increases heart rate and strength of contraction. At high doses, it constricts blood vessels. The gonads, then, are also part of the endocrine system, and they promote sexual maturation to puberty. And they're responsible, of course, for seeing to our reproductive needs. In males, the gonads produce androgens like testosterone. And in the females, the ovaries secrete progesterone and one other one. I'll come across it here. Disorders of the pituitary gland include diabetes insipidus. Now, we think of diabetes as being a disease of the pancreas, which it is, but it's the pituitary gland that secretes the antidiuretic hormone. And in people who have high sodium levels in the blood, the antidiuretic hormone is shut off so that your body can get rid of that sodium by urinating it out, because we know that water follows sodium, or sodium follows water, however you want to view that. And in diabetes insipidus, because of high sodium levels, you're constantly going to the bathroom, much like a diabetic would, in order to get rid of those high sodium levels. And diabetes insipidus is a result of a deficiency in the posterior pituitary gland. Some of the things that you'll find with diabetes insipidus is, of course, similar to diabetes. The patient will be constantly thirsty, constantly going to the bathroom, may suffer from muscle spasms and hyperreflexia from the high sodium levels, and if the polyuria continues, they certainly can eliminate not only too much sodium, but they can eliminate potassium as well, and magnesium, leading to the muscle spasms. Coma and altered mental status goes along with the dehydration that's associated with diabetes insipidus. The therapeutic interventions for the treatment of diabetes insipidus include, of course, replacing the fluid that's been lost with saline, and then often requires desmopressin, which is very similar to vasopressin. Vasopressin is your antidiuretic hormone. So in these particular patients who suffer from diabetes insipidus, the treatment might include replacing that vasopressin antidiuretic hormone with desmopressin. Monitoring serum sodium and urine volume, urine output is important in these patients as well. With hypopituitarism, that's a deficiency in the pituitary hormones, which lead to a abnormal regulation of TSH, and TSH is certainly important in regulating the thyroid gland, and so hypopituitarism leads to hypothyroidism. You can have different either deficiencies or excessiveness in these thyroid hormones, and essentially pituitary adrenal insufficiency as well, which, when hypopituitarism occurs, the signals to the adrenal glands can be absent. So the ability to stimulate the adrenals to release adrenaline into the bloodstream could be suppressed. Disorders of the thyroid gland include hyperthyroidism, and that's where the thyroid gland is overactive. Because the thyroid regulates metabolism, you're going to see just an increase in the metabolic rate. So things like tachycardia, tachypnea, heat intolerance, diarrhea, weight loss, constantly hungry, sweating because the adrenals are under the control of sweat glands are under the control of adrenaline, and if your metabolism is jacked way up, you're secreting the adrenaline, which causes the tachycardia and the tachypnea and the sweating. They may be irritable. They may suffer from a condition known as Graves' disease, and a person with Graves' disease may have really buggy eyes. An old actor who's no longer with us by the name of Marty Feldman had really buggy eyes, and that was an indication of Graves' disease. What's a concern to us in a person with hyperthyroidism is if they develop thyrotoxicosis, they can get what's called a thyroid storm. And with a thyroid storm, their tachycardia is typically life-threatening. as well as by that point they're dehydrated, they have electrolyte disturbances and all kinds of things from all that has been going on. So a thyroid storm is a true medical emergency. It's identified as a extreme hypermetabolic state. Again, the respiratory rate is fast, they're tachycardic. They can have atrial fib as a result of this as well. Therapeutic interventions for the treatment of hyperthyroidism is to be supportive. If they're showing any signs of shock, to certainly manage the shock as you would any shock. If they've got AFib and it's certainly at a really fast heart rate, using drugs that would help slowly or convert the AFib may be appropriate. It depends somewhat on how long they've been in the atrial fib. If they've been in the atrial fib, if this were sudden onset, then it might be safe to convert that AFib, but only if it's causing serious symptoms. We use adenosine for tachycardic rates, but if we know it's AFib, A-flutter in the 180s, certainly something like a calcium channel blocker like cardizem would be appropriate, or a beta blocker like metoprolol would be appropriate as well. Cardizem could be, anywhere from 15 to 25 milligrams IV, and then the metoprolol, we give 5 milligrams, wait 5 minutes, give 5 milligrams, wait 5 minutes, give 5 milligrams, and then the maximum we would give would be the 15. Steroids also could be an important therapeutic intervention, but not something that we'll do pre-hospital. Hypothyroidism occurs when the thyroid gland is underactive. What you'll see is a real elevated TSH level. You'll get pituitary enlargement, or you get a big goiter in the neck as a result of the hypothyroidism. And it's often caused by an iodine deficiency, and that's why, at least in most of your salt that you buy at the store, that's why it's important to buy the iodine, buy the salt that contains iodine, because otherwise, from a dietary standpoint, there aren't that many other sources where we can get iodine. And so by having it in our salt, that certainly is one way that we can get the iodine that we need. Hypothyroidism also can be caused by a congenital or an abnormal thyroid formation. Your history and physical findings is somebody with hypothyroidism. One thing that the thyroid is also important for, but not only for metabolism, but organ growth and those sort of things. So the thyroid hormone is critical for brain growth. Patients with hypothyroidism, they believe that this, like diabetes, is an autoimmune process where the body makes antibodies that actually attack the thyroid and destroy it, much like the destruction of the islet of Langerhans in the pancreas. If severe enough, hypothyroidism can cause what is called a mixed edema coma, and of course we wouldn't. We would have a person that probably was in a coma of unknown etiology, and it would take a very thorough history to and labs to determine the presence of hypothyroidism. Therapeutic interventions is to be supportive, and certainly if they're in a coma, the ABCs, temperature regulation, and prevention of shock. Hyperparathyroidism is the oversecretion of the parathyroid hormone, and the parathyroids, remember, are those glands within the thyroid that are responsible for calcium uptake and distribution. A person with hyperparathyroidism would have excess calcium in their blood, which would be hypercalcemia, which many of your electrolyte disturbances, when there are too much of the electrolyte in the bloodstream, leads to these very common symptoms of muscle weakness, fatigue, nausea and vomiting, and of course the vomiting could lead to volume depletion as well. Hypothyroidism, it should be hypoparathyroidism, muscle weakness, fatigue, vomiting, volume depletion, that sort of stuff. And as a result, with these type of endocrine disorders, our therapeutic interventions are just to be supportive. If they're dehydrated, as evidenced by a orthostatic vitals check, if they're lightheaded, dizzy, nausea, vomiting, treating them with fluids if they're orthostatically positive, or, giving them something for their nausea would be appropriate. Okay. Again, it's the hypoparathyroidism is an autoimmune disease, and one of the things that certainly would cause hypoparathyroidism is the removal of the thyroid gland. In patients who develop thyroid cancer, thyroid tumors, they often have to have the thyroid gland removed, in which case the parathyroids would be removed as well, and then they have to take the hormone Synthroid, which simulates the proper function of the thyroid gland, but then they also may have to take some sort of supplements because their ability to regulate their calcium is going to be affected by loss of the thyroid glands. They may have an altered mental status with hypoparathyroidism. They may have paresthesia of the extremities, muscle cramping, muscle spasms, twitching, tremors, seizures. And again, many of these symptoms are common when we have endocrine emergencies. Many of these symptoms are common because endocrine emergencies lead to things like electrolyte imbalances, either too much sodium, potassium, calcium, magnesium, or not enough sodium, potassium, calcium, magnesium. And it's very difficult to determine, which one of these conditions it is. It requires a very thorough history and an understanding of those types of endocrine disorders. Now, another disorder of the endocrine system includes a disorder of the pancreas, in which case you're going to get two different presentations, certainly hypoglycemia or low blood sugar, which we know in a type 1 or type 2 diabetic, type 1 requiring insulin to manage their disease, and type 2 requiring exercise, diet, medication, and perhaps insulin, depending on the severity of their type 2. In any event, the low blood sugar comes on very suddenly. It occurs in patients who take their medication, but they don't eat, or they don't eat the right stuff, or they have excessive activity. And in some patients, they can be hypoglycemic and not really aware of it. And this occurs in those people where they chronically run low blood glucoses. If a person rarely ever runs a low blood glucose and then gets a blood sugar of 50, it may affect their mental status. Whereas if somebody chronically runs low blood glucoses, they could have blood sugars in the 20s and still be alert, awake, and talking to you, and you wouldn't have any idea at all that they have a low blood sugar. And that just comes with low blood sugar tolerance. And there are those people out there that have hypoglycemia but don't have diabetes. Diabetes typically is a disease of hyperglycemia. And the hypoglycemia comes from trying to manage their hyperglycemia. But there are those people out there who suffer from chronic hypoglycemia, which doesn't have anything to do with diabetes, but more to do with, perhaps the just the inability to the ability for the insulin that they do have to move the sugar quickly out of the bloodstream. Hypoglycemia is defined as blood glucose less than 60. In here it says less than 50 milligrams per deciliter. A patient with hypoglycemia may have the polys. No, excuse me, that's hyper. A person with hypoglycemia may be hungry and may be agitated, have an altered mental status, may be sick to their stomach, may be quite confused. We used to call this hypoglycemia, we used to call it insulin shock because it was caused by insulin, too much insulin, which drives the sugar low, and it presented like shock. The patient was pale, cool, clammy, tachycardic with an altered mental status. So that's one way to remember it, hypoglycemia as insulin shock. The goal in managing hypoglycemia is to increase the blood glucose level. And in increasing the blood glucose level, there's a variety of things that are available to us. They could ingest a glucose paste. They could drink some orange juice or some hard candy. There's also, certainly glucose tablets that a person can buy as well, with each one containing about 4 grams of sugar. So that if they'd eat, 3 or 4 of those tablets during a low blood glucose, they would be able to raise their sugar significantly. When we arrive, if their mental status is altered and they're not able to ingest glucose paste or eat a tablet or drink something that has sugar in it, we can establish an IV or IO and give them dextrose, D50, either half an amp, which would be 12.5 grams of sugar, or a whole amp, which would be 25 grams of sugar. Glucagon is a hormone, certainly, that the body produces, and if we're unable to get an IV established and we're trying to raise the blood glucose in somebody whose mental status is altered to the point where they can't swallow, giving them 1 milligram of glucagon IM, the glucagon will get into the bloodstream and it'll travel to the liver, and if the liver has sugar stores in it, it will cause the glycogen in the liver to be broken down to glucose, where it can be used in the cell. So the glucagon will raise the blood glucose, but only if there are glycogen stores in the liver. So very, very, very young children don't have much for glycogen stores, and diabetics who chronically run really low blood sugars don't have much for glycogen stores in the liver as well. So your glucagon may work in raising the blood sugar enough to buy you some time to where they wake up and could actually eat or drink something. But after the symptoms disappear, in other words, once you give them sugar and you wake them up, it's important to give them something that's going to hold them over. And as diabetics, they should know that themselves, but certainly it's important that once we get the blood glucose to where they're awake and talking to us again, that if we don't give them some sort of complex carbohydrate, then their blood sugar is going to plummet after we leave. So giving them, we use what's called the rule of 15. We'll give them 15 grams of carbohydrates and then wait 15 minutes and reassess their blood glucose. And if it still is low, or if it does start to drop or trough, then we go ahead and give them another 15 grams of carbohydrates. Now, 15 grams of carbohydrates could be something as simple as a ketchup packet, something as simple as 2 soda crackers, 1 piece of white toast. Others will take those crackers or bread and they'll put some peanut butter on it. And while the peanut butter isn't a carbohydrate, it's primarily a protein. The protein, along with the white bread carb, will help sustain that blood glucose longer. White things, potatoes, rice, white bread, crackers, anything white is going to convert quickly to sugar. It's a simple carbohydrate. It's not a real complex carb. Complex carbs include things like whole wheats and grains, nuts, those sort of things that take longer to digest, so the sugar is slowly converted rather than a peak and a trough. Excuse me. Hyperglycemia occurs when the insulin is ineffective in moving the sugar from the bloodstream into the cell. So it hangs out in the bloodstream, causing the blood glucose to rise. It can lead to a condition known as diabetic ketoacidosis, but prior to that, in a person with hyperglycemia, as I had mentioned, they're hyperglycemic because their insulin is ineffective or their pancreas is not secreting insulin. As a result, their body attempts to get rid of that sugar by urinating. Well, in addition to urinating, water, you also eliminate electrolytes. So we've got an electrolyte depletion, we've got a water depletion, so we become dehydrated. And because sugar's not going into the cells choose to metabolize without sugar, and in order to make energy, then they'll burn fat. And that fat metabolism leads to ketone production, and ketones, a byproduct of fat metabolisms, ketones are acids. So as the acids build up in your bloodstream, it lowers your pH and makes your blood acidic. So a person in diabetic ketoacidosis is dealing with a couple problems. One, they're extremely dehydrated and their electrolytes are out of balance, particularly their potassium. And two, their blood is full of acid and their pH is extremely low. Now, the treatment for the diabetic ketoacidosis is to lower the blood sugar. One thing to keep in mind about hyperglycemia when we compare it to hypoglycemia, hyperglycemia occurs over days, 7 to 10 days. So it's not something that you're going to see happen immediately like you do with low blood sugar. It occurs in diabetics who have not been diagnosed with diabetes. It occurs in diabetics who don't take their insulin or who don't take their medications or who eat the wrong foods and are non-compliant in their treatment plan. Diabetic ketoacidosis is diagnosed when we have sugar in the urine, when we can identify a hyperosmotic state. When a person is hyperosmotic, they're going to be getting rid of water, which leads to dehydration. In an effort to eliminate the acids in the blood, patients with diabetic ketoacidosis will be creating lots of CO2 in their bloodstream. As the bicarbonate that you have in your blood combines with the hydrogen ions of the acid, it's going to form carbonic acid, which dissociates into water and CO2. So in order to get rid of that excess CO2, you breathe deep and fast. So a person with diabetic ketoacidosis is going to have a very deep breath and a very fast breathing rate, which we call Kussmaul's breathing. You may be able to smell the ketones in the blood or in the breath of the patient. There's only about 35% of the population that can actually smell that. The vast majority of people can't. So if it isn't present, it doesn't mean they don't have diabetic ketoacidosis. It just means you could be one of those who can't smell the ketones. The treatment is to give fluids. First and foremost, we need to replace the fluids, but slowly. The dehydration occurred over days. We need to correct it over days. Replacing sodium quickly in patients, as well as replacing just volume quickly in patients, will lead to potentially cerebral edema as well as potassium shift, causing a life-threatening hypokalemia. So we need to administer fluids. This may take several liters in order to hydrate them slowly over time while measuring their potassium levels. They also need to be given insulin, and oftentimes their sugars are high in the 6, 7, 800s, so they'll put them on an insulin drip, and they will run the insulin in until the sugar's down to about 250 or so. Then they'll shut the drip off and put them on a sliding scale of insulin. It's very important to monitor these patients, as they also may need things like calcium, potassium, those sort of things, depending upon how depleted their electrolytes were as a result of the dehydration. Hyperosmolar hyperglycemic non-ketonic coma, or HHNC. This occurs particularly in elder patients where they have little or poor insulin, but the insulin they have is just good enough to keep their cells from metabolizing fat, but not enough to keep the sugar low in their blood. So gradually over time, a couple weeks, 10 to 14 days, these patients will develop really, really high blood sugars in the thousands, but not show signs of diabetic ketoacidosis because their insulin is good enough just to get the sugar into the cells, but not good enough to lower the blood glucose in the blood. So they have all the dehydration. They're going to have the electrolyte disturbance, the low potassium, the severe dehydration, but they're not going to have the deep, rapid breathing or the metabolic acidosis. Treatment for those folks, of course, would be to replace the fluid and to give insulin. Physical findings in somebody with HHNC include severe volume depletion, central nervous system dysfunction, warm, dry skin, dry mucous membranes, poor skin turgor, tachycardia, weakness, along with the old CNS, central nervous system dysfunction. Your brain does not work well at all when it's dry. So with the severe dehydration comes the altered mental status or coma. Physical findings in somebody with high blood sugars, whether it be HHNC or diabetic ketoacidosis, is they get the polys. They get polyuria, they pee a lot, they get polydyspnea, they're thirsty, constantly thirsty, polyphagia, they're constantly eating and hungry. They may have orthostatic hypotension. They may even have hypotension laying flat. They're altered. Their mental status could be altered because of the dehydration, and if they get severely dehydrated, of course, that can lead to lethargy and coma. There is a condition with diabetes that occurs in pregnancy. It's called gestational diabetes, and it occurs as a result of impaired glucose tolerance, or the glucose that's being secreted is not functioning properly. And certainly if left untreated, those really high blood sugars will lead to the hyperosmolarness, will lead to the excessive urination, the electrolyte depletion, and dehydration. But we have to think of the fetus as well, and certainly untreated, unchecked dehydration in a pregnant female could lead to fetal death. Often the gestational diabetes is controlled with dietary modification, maybe perhaps some insulin therapy, or some sort of oral hypoglycemic. Gestational diabetes occurs primarily in women who are 25 years or older, who are obese, who have probably a borderline impaired insulin secretion to begin with. If they've had large babies prior, they're at a higher risk of gestational diabetes. if they have a first-degree relative that has a history of diabetes, if they have reoccurring infections, and those African American and Hispanic ancestry, those African American or Hispanics are at greater risk of developing gestational diabetes. Treatment would be dietary modification and insulin therapy, as well as perhaps an oral hypoglycemic to help keep their blood sugars low. Complications of diabetes at the microvascular level, destruction of the small microvessels lead to blindness. In fact, the number one cause of blindness is diabetes. It leads to kidney problems, primarily hypertension. Chronic hypertension leads to kidney damage and kidney failure. Neuropathy is a destruction of the vessels, a destruction of the nerves, not the vessels, the nerves, a destruction of the nerves. And a person with diabetic neuropathy can have severe pain in the feet and the ankles and the legs, it can be managed, at least the discomfort can be managed somewhat by medications. And then autonomic neuropathy, neuropathy that occurs as a result of chronic high blood sugars destroying other nerves in the body that lead to things like, type 1 diabetics are more prone to what we call silent MIs, not having the classic crushing substernal chest pain because of the nerve damage from the autonomic neuropathy. Some other microvascular complications, larger vessel complications include peripheral artery disease as well as cerebrovascular disease and coronary artery disease. So diabetes increases your risk of stroke, increases your risk of heart attack, and increases the risk of peripheral vascular disease. Adrenal insufficiency, when the adrenal glands aren't working properly, this can cause a rapid deterioration of the cardiovascular and metabolic status in the patient, because adrenaline is certainly the primary neurotransmitter for the sympathetic nervous system, and our ability to balance our parasympathetic nervous system could be lost, leaving the parasympathetic nervous system unopposed, leading to severe bradycardia and other problems that could be life-threatening. Addison's disease is a disease that is the name of the disease for adrenal insufficiency. And you can have secondary adrenal insufficiency from taking drugs like corticosteroids, particularly prednisone. Patients who take prednisone for long periods of time can end up with secondary adrenal insufficiency. The history and physical findings of adrenal insufficiency include weakness, fatigue, anorexia, hypoglycemia, weight loss, nausea, vomiting, abdominal pain, many of the different things that you see with electrolyte disturbances as well. They may also get skin pigmentation or darkening of the skin. In the previous slide, you saw the skin pigmentation of those gums, which is a telltale sign of adrenal insufficiency. They may have salt craving, may have diarrhea, fainting, dizziness, hypotension, tachycardia, and dehydration as well. Therapeutic intervention is to be supportive, monitoring their airway, breathing, and circulation, gain IV access, and if they have electrolyte disturbances, sodium, potassium, magnesium, calcium, correcting those, and that's something that will be done in the hospital. Cushing's syndrome is the result of an overproduction of corticosteroids. A person who has Cushing's syndrome overproduces aldosterone and cortisol. As a result, they develop a moon face, a typical big round full moon face with fat accumulation. Here you see it above the eyelids, but certainly above the clavicles and the upper back. They develop what's been called a buffalo hump. They get that hump in the back. And the treatment is to manage the symptoms that are associated with this corticosteroid overproduction. Again, this also can be caused, the buffalo hump and the moon pie face also can be caused by chronic steroid ingestions like prednisone. Malnutrition is when the body receives an inadequate energy to meet its metabolic needs, and of course somebody who's suffering from malnutrition is dizzy, faint, has excessive weight loss, has neurological and neurofocal changes as well. And for those who are malnourished, we treat the symptoms by identifying electrolyte disturbances, volume depletion, lack of certain nutrients, and get them hydrated, get their electrolytes balanced, get them on a so many calorie diet so that they can get the nutrition they need to thrive. Some conditions that occur with inadequate caloric intake include a condition known as marasmus, and that's just the overall lack of calories. Somebody who doesn't consume calories or doesn't consume any, somebody fasting or something like that. Another one is kwashiorkor, and that's an inadequate protein calories compared with total calorie intake, and that's maintaining enough calories just to maintain your weight. And there's a formula out there that if you look at how much you weigh right now, you can plug some numbers into this formula and it'll tell you how many calories a day you need to maintain that weight. And if you want to lose weight, the solution is simple. You have to reduce your caloric intake and move more. Alcoholic ketoacidosis, this is called AKA, and this is where your body resorts to alternative energy sources. And we again see this in alcoholics who often don't eat well. So the body attempts to get the calories from the alcohol consumption. And of course, there's only certain types of calories and certain types of nutrients within alcohol. And if that is the primary caloric intake is alcohol, we know how damaging that can be on the liver, the kidneys, overall weight, and heart disease, increased risk of stroke, all those things related to just resorting to using the energy found in alcohol. Inadequate vitamin intake. Fat-soluble vitamins are stored in the liver, and because they're stored in the liver, they can be taken out when needed, and they include vitamin A, vitamin D, vitamin E, vitamin K, certainly all very important vitamins in maintaining homeostasis. And if we eat from the 5 major food groups and a reasonable caloric intake, we just don't have any of these problems. Many people, however, when they age, don't do as well and take a multivitamin. And what we're seeing, of course, missing here for neurohealth is these water-soluble vitamins. Like they're not stored in the body. We have to replace them every day. And they include vitamin B1, which is thiamine, vitamin B2, which is riboflavin, vitamin B3, which is niacin, vitamin B6, which is pyridoxine, and vitamin B12, which is cyanocobalamin. And the B vitamins are very important to overall nerve health and muscle function, those sort of things. So it's important that we get an adequate amount of these, and if we don't, taking that multivitamin with all these Bs certainly is helpful. Inadequate mineral intake. Minerals are certainly important to body function, iron being one of the minerals that's important. Those who lack iron, who have iron-poor blood, can become or are said to be anemic. And with anemia, you don't have an adequate number of red cells, and red cells are important for hemoglobin, and hemoglobin is an iron-containing molecule. So if we don't get the iron, we don't make the hemoglobin, and as a result, we become anemic because of our inability to carry oxygen on our red cells. And anemia certainly can lead to an increased risk of stroke and increased risk of heart attack as a result of inadequate tissue oxygenation. So with that, we've gone through all the different endocrine emergencies, and as you can see, they are quite complex and complicated. Hopefully we've been able to answer a few of your questions or thoughts that you might have about this, again, very complex system that you talk about here in paramedic class, but short of something like a thyroid storm, short of hypoglycemia or hyperglycemia, many of the other endocrine disorders that we discussed are not very common, and when they do present themselves, they all present very similar, with the weakness, the fatigue, the nausea, the vomiting, the altered mental status, those sort of things. So it's very difficult to in the field determine or diagnose an endocrine disorder of that type. So if you have any questions, you certainly know how to get a hold of me, and with that, I will talk to you soon. Bye.